All right. Well, thank you very much for sticking with us today. Next, we have Dr. Anthony Amato, who is the Brigham and Women's Hospital Distinguished Chair of Neurology. He is also the Chief of Neuromuscular Division and Director of Clinical Neurophysiology Laboratory at BWH. He is a professor of neurology at Harvard Medical School, and he was also a founding member and has served on the executive committee of the Muscle Study Group, which has now grown over 150 scientific investigators around the world. So, Dr. Amato, I will go ahead and get your slides up, and you can go ahead and present.
Okay, we're going to do the next one. I'm just going to start with the case. Well, everybody who I see, and so I saw a 63-year-old woman with a history of generalized myasthenia gravis who was diagnosed earlier in the year. She had chest CT that showed thymic hyperplasia. She had antibodies, acetylcholine receptor antibodies, and a decrement on repetitive nerve stimulation. She was initially treated with prednisone 100 milligrams every other day and mestonate or pyridostigmine, and improved and gradually was tapered to prednisone 35 milligrams every other day. When she represented with a flare with increasing shortness of breath and weakness in her arms and legs. Okay, next. And on exam, she had ptosis or droopy eyelids at rest. Her extraocular movements were full, but her speech was nasal. She had weakness of her eyes, couldn't close her eyes tightly or close her mouth, was unable to lift her head off a bed when supine, and she had mild weakness in her extremities. She couldn't sip water from a cup without coughing, and her pulmonary function tests were reduced, so she only had like 14% of a predicted value. Next. And so, again, I just asked, how might I, as a doctor, treat her? So in myasthenia gravis, as a basic, the nomenclature is myo being muscle and asthenia being weak, and it came from the Latin derivation of weak muscles, and the gravis is from it used to carry a grave prognosis. That's not the case anymore now that we have good treatments and ICUs when people go into crisis, but there still is a rare mortality rate of, usually 1 in a million people might pass away from myasthenia gravis. Next. In terms of presentations, I probably don't have to tell many of you on the webinar, but half of people with myasthenia initially present with isolated ocular symptoms, so droopy eyelids, blurred or double vision. Ptosis or droopy eyelids is the presenting manifestations in 50 to 90%, while about 15% of people complain of blurred or double vision. And if not the presenting symptoms, ocular involvement with ptosis or blurred or double vision occur in 90 to 95% of patients with myasthenia gravis at some time. The voice can be affected, so it can be a soft hypophonic voice, either from the muscles affecting the vocal cords or your lung muscles. You can also have dysarthria, what we say is slurred speech, and that could be from weak muscles in the mouth and the pharynx and the tongue. And there can be bulbar weakness, and that's kind of face and tongue that can give you swallowing difficulties and occasionally breathing difficulties. Next. The limb muscles, arms and legs, can be the presenting manifestations in 20 to 30%. Usually affects the proximal muscles more, so it's kind of the shoulders and the hips, but about 10% of patients can start and even just manifest entirely with distal weakness, so foot drop or finger drop. I think Gill had one of the early papers on this. And then some patients present with a head drop, so from weakness in the back of the neck. Next. Ventilatory weakness is a rare presentation, but it certainly can occur with untreated people and in patients if they get very refractory or they go into crisis. And this is the reason for the mortality in myasthenia gravis and the historic designation of gravis. Things that we can do at the bedside is just have someone take a deep breath and kind of see how long somebody can count on a single breath. So I multiply the number patients can achieve by 100, and that gives me about an estimate of a vital capacity. So for example, if they can count to 35 on one breath, times 100 is 3,500 cc's is an estimate of the vital capacity. And for my own sake, I know that if somebody can have a vital capacity of at least 1,000, they're not in an immediate crisis. Next. As I missed Gil's beginning, but there are antibodies how we do for diagnosis. So acetylcholine receptor binding antibodies are certainly the most common, and you can do modulating and blocking as well. In terms of the binding antibodies, about 78% from the large Duke series if they had generalized myasthenia gravis, had antibodies. They're less common, maybe 50%, 60% in patients that just have ocular myasthenia gravis. Rare patients might have modulating antibodies without binding. So the binding is the best, but you increase their sensitivity of the diagnosis by doing some modulating too. The blocking usually doesn't add much. Occasionally you can have a negative antibody initially. So sometimes if they're negative, I'll repeat it in 6 months. And Duke has shown that about 15% of patients initially negative will be positive. And as Gil had mentioned, there's some sub-base assays which will pick up additional seronegative patients. Next. About a third of patients that don't have acetylcholine receptor antibodies have antibodies directed against muscle-specific kinase protein, or what we call MuSK. Patients with MuSK can look a little bit different than the acetylcholine receptor antibody positive. They may have more bulbar symptoms without eye involvement, so more slurred speech or swallowing without ocular, but and sometimes have more proximal weakness. When they don't have ocular, sometimes it can get misdiagnosed as having a myopathy when they don't have the droopy eyelids or the eyelids. And then about 10% of the remaining patients, again, less than 5%, will have antibodies to LRP4 or agrin. And it's interesting the way how these proteins all kind of interact with one another and help anchor the acetylcholine receptor on the muscle at the end plate. Next. And in terms of diagnosis, we do EMGs and nerve conduction studies. The main thing we do is a repetitive nerve stimulation. And normally if you stimulate nerves at 2 to 5 per second, the amplitudes of our responses don't change, but in myasthenia gravis, we see a decrement. And in rare patients that don't have, again, we still suspect the diagnosis, but our rep stim is normal or antibody negative, then one could do single fiber EMG to try to diagnose an abnormality. The problem with that is it's very sensitive. So you can have any kind of abnormality, a muscle disease, a nerve disease can cause an abnormality. So it's not specific for myasthenia gravis. Next. So this is a figure of a repetitive nerve stimulation. You'll notice that the amplitude is higher in the first kind of waveform, and it kind of goes down. And like in a patient who's normal, the size of those waveforms are all look the same, but in myasthenia, they decrease, as you see here. Next. And so, again, the way I treat patients is dependent on the severity of myasthenia gravis. You will note, and if people go to different doctors, people may treat patients differently, and there are guidelines of that, but and as Gil mentioned, people have guidelines on how they would do, but anybody can get a guideline, and samely trained individuals, and they're going to treat the patient differently. So there's no right or wrong way, or I would say there may be some wrong ways, but there's no right ways. There's lots of right ways somebody can treat patients. But I do personally treat depending on the severity. So there's ocular, mild, generalized, moderate to severe, or crisis, the way I kind of categorize and treat patients. And so most importantly, we want to follow what we call supportive care, the ABCs, airway, breathing, and circulation. So when we see somebody, we want to assess their respiratory status, follow their pulmonary functions, which is the forced vital capacity. If you have that, you can't, you're not going to have that in the clinic office or at the bedside if a person's in the hospital. That's why I mentioned how I do the bedside tests, a poor man's way of checking on lung function at the bedside or in clinic. And as I said, that's just having a patient take a deep breath and counting by 100 gives me an estimate of a vital capacity. And we want to make sure that vital capacity is at least, we get concerned that we might have to intubate when it's less than 15 milliliter per kilogram, although, you're watching somebody really closely when it's 20 or 30 milliliter per kilogram. Next. And other supportive measures can be done, like aside from intubation, sometimes just using a non-ventilator mask, BiPAP or CPAP. If somebody's in the ICU and they can't eat, we have to provide nutrition. Patients who don't move their arms and legs are at risk for DVTs or blood clots in the legs. So you have to do blood thinners so they don't get a blood clot. And as Gil mentioned, because exercise is good, so we want to get patients physical and occupational therapy next. But in the nuts and bolts in terms of medical treatment, how do we do things? So an ocular myasthenic, we might just try out with pyridostigmine or mestinon. My own bias and experience, it helps with the droopy eyelids, the ptosis, but it's a little less helpful in patients that have blurred or double vision. And the reason why that is each eye is innervated by 6 different muscles that kind of move the eyes in different directions, up to the side, down, the whole circular movement of the eye. And if just one of those muscles in one of the eyes is just a little off, then you could have blurred vision. If there's a lot off, you can get double vision. And mestinon's kind of a crude thing. It can help, but it might not make everything 100%. So that's why it often isn't completely helpful for double vision. Do I try it in double vision? Yeah, because sometimes I'll get successful. Oh, can we go back? Can you go back? Nope. Yeah, you went back too far. Okay, now I can't even see. That's too blown up.
What slide do you want to see, Dr. Amato?
I was on the ocular myasthenia. I was talking about mestinon. But I can't see. Now the slide on my screen is just massive. I see treatment.
Oh, I don't know. The format hasn't changed on my end.
All right, I'm not sure what's going on. So, so then the next that I try for ocular is prednisone. So I can see it a little bit now. And so, yeah, I think it's just on my slide in my computer
Okay.
that I'm seeing it. I just people, I can see the text. I'm glad you can see my slides.
Yeah.
So next I do, and you're more important than me. So the next thing is I often will try prednisone. If they have double vision, I sometimes get away with it with ptosis. Rarely Mestinon helps with double vision. Ptosis it helps with, but often I'll go with prednisone. And usually I'll start at a low dose. So I'll usually start at maybe 10 milligrams a day, and then I'll increase it by 5 milligrams every 5 to 7 days until symptoms remit. And I try not to go more than 40 or 50 milligrams a day. And most of the time you don't have to. And then whatever dose that seems to be effective. I mean, if I start them on 10 and it's good on 10, then that's good, but then they can go to 15, 20, 30, whatever dose it is that relieves the blurred vision, double vision, ptosis, then I keep them on that for a month, and then I slowly taper. And then when I taper, I taper more slowly than I increment. So I'll taper no faster than 5 milligrams a month. And then when I get to between 10 and 20, I'll decrease it by 2.5 or 5 milligrams a month. And I try to find that lowest possible dose that controls the symptoms. And so, I mean, it might be a little roller coaster ride until you find what that is, but I think you want to find that lower dose so you can limit side effects. Next. In patients who have generalized myasthenia, so if it's mild or moderate, again, I put people on Mestinon, again, usually 60 milligrams, 3 to 4 times a day. If people need more than 5 Mestinon, 6 of 60 milligram tablets, it's not going to help them adding more. It's probably just going to give them more side effects like cramping and diarrhea and saliva. And then I also start with prednisone, and usually, again, 10 or 20 milligrams a day. Now, sometimes you can go with a high dose approach, and so that could be like a 0.75 milligrams or 1 milligram a day up to 100 milligrams. I think when I was trained, this is how we were trained. But people, about 10% or so of patients that are put on a high dose of prednisone can get weaker within the first 7 or 10 days. So, and we found really by use of these, like the mycophenolate trial that Gil had mentioned, the CellCept trial, that low dose seems to work. So the good thing about the high dose is that patients can get better quicker, but they can get worse, and they might be on higher doses of prednisone, have more side effects than they need. Going on a low dose, it can take a while till they build up to whatever that dose is that seems to correct it. So usually if I'm seeing a patient as an outpatient, they have mild disease, I usually start with a low dose. If they have more severe generalized myasthenia, they're already in the hospital, I want to get them better quicker, that's when I'll go to the higher dose. And again, the start low, go slow approach is the 10 or 20 milligrams, increasing by 5 milligrams every 5 to 7 days until I find that dose that works. I keep them on it, and then I slowly taper. Next. And then when you're on steroids, because there's side effects, it can pull calcium out of your bones, give you osteoporosis and brittle bones. You need to supplement that with calcium. Sometimes I'll just use Tums, because one of the other side effects of steroids, it can give you heartburn. and Tums it can help with the heartburn, and it's full of calcium. So I usually give Tums 3 times a day. A supplement with vitamin D. I usually get a bone density at a baseline and repeat it. Instruct patients on a low sodium and carbohydrate diet because it can increase your blood pressure. It can make people hungry, predispose them to diabetes. So that's why you're counseled on not putting a lot of salt on your food and laying off on the candies. And we monitor the blood pressure and your electrolytes in your blood, your fasting blood sugars, and closely, and watch for cataracts that can occur with steroids. And again, exercise is really good. It helps limit the side effects like osteoporosis that can occur with steroids. Next. Thymectomy then is used, and as Gil mentioned, he ran the large international trial of thymectomy in patients that had non-thymomatous acetylcholine positive myasthenia gravis. And before that trial, we thought it might work, but we didn't know. Now we do. So in anybody who's generalized myasthenia gravis, have acetylcholine receptor antibodies, I do counsel patients and suggest thymectomy. It's best if done early within the first 3 years. We don't know if it works in patients who are antibody negative. Again, there's not a lot of great studies. The anecdotal reports suggest it might not be as beneficial, but we don't know. The same thing with the musk. We don't think that it works, but it hasn't been studied per se in that. Likewise, in patients who are just ocular myasthenia, we have no data in regards to whether thymectomy works in just patients that have ocular myasthenia. Next. And again, those are the references to the studies that Gil led, and I saw in the previous talk he mentioned these studies and the results. So next. We use plasma exchange or intravenous globulin mainly in patients who are in crisis, but in some patients that don't have a complete relief of symptoms with corticosteroids, prednisone, or other immunotherapies like azathioprine, Cellcept. We may use these as maintenance. So I often use it as maintenance. And both IVIG and PLEX seem to be effective and equal in terms of efficacy. Next. So, but again, with either of these, like plasma exchange will get the antibodies out, but then you'll have a rebound. So you need to do more than just give plasma exchange. So with, if you're going to give plasma exchange, you also need to be on immunotherapy. Next. And again, intravenous gamma globulin has been shown to be effective in a number of randomized trial. Again, no difference in efficacy when compared to plasma exchange. When I give IVIG, I do a 2 gram per kilogram dose over 2 to 5 days. If they're in the hospital, usually if they're in the hospital, I'll give it over 5 days just to give them more time to rest and recover. As a maintenance therapy that I do, I usually try to start off with a monthly dose of 1 gram per kilogram, but the dose is individualized. Some people might need it every 2 weeks. Some people can get by with every 8 weeks. Next. And these are just some papers that compared it, just to show you that efficacy seems to be the same between IVIG and PLEX. Next. And here was another paper showed similar efficacy, but IVIG seemed to be a little less costly than PLEX, probably because when you do PLEX, you're admitting somebody to the hospital. They're going to be in the hospital for 2 weeks, because they usually get 5 or 6 exchanges over 10 to 14 days, while IVIG, you can do it over 5 days. So ultimately, the longer admission, and the greater the cost. Next. And again, there was another study out of University of Rochester that again showed that, again, similar efficacy, but IVIG was more cost effective. Next. And more recently, in the last few years, we found that subcutaneous immunoglobulin can be effective with myasthenia gravis. And so I might use this in patients who, as I said, I usually try it once a month if I'm on maintenance, but if somebody needs it, every 2 weeks or so, and they have to come to a hospital or an infusion center, sometimes it's easier to give subcutaneous immunoglobulin because it can get shipped to the house, and patients can administer it, be taught how to administer it themselves, put a needle under the skin and the belly and run the infusion for an hour or so under the skin twice a week. They're taught that, and it can be effective. And patients who have a lot of headaches with intravenous gamma globulin as a side effect, subcutaneous immunoglobulin seems to be better too. And also if people travel a lot, and it's hard for you to travel if you need to get IVIG, but you can take your subcutaneous immunoglobulin, mix it, and treat yourself if you're traveling. Next. And then there are a number of second line agents. So again, so sometimes we do these at the time that we start prednisone, or sometimes we'll add this if, again, we can't get control of the myasthenia gravis on just the low dose, we'll add it. We don't really know. There's equipoise, and we don't know whether, again, myasthenia does better if we start it treating patients initially with prednisone and the second line immunotherapy at the same time, or if you just wait and only use it if you can't get control of the myasthenia gravis. Again, I often will try to see if I can get away with prednisone alone just to reduce the side effects. The times that I do one of these other agents is if they're at risk for complications of steroids. So if somebody is overweight, they have diabetes, bad high blood pressure, have osteoporosis, and bone loss and contractures, then I know that I really do want to try to get them off of prednisone as fast as I can. So those are patients who I definitely will add a second line agent right away. And the most commonly ones used are azathioprine or Immuran. Methotrexate has been used by some, but there was a negative trial. Mycophenolate mofetil is very popular CellCept, even though there was 2 randomized trials that were negative. Many of us still think it probably works in a subpopulation of patients. It just takes a long time. And maybe the outcome measures that were done in the studies weren't sufficient enough to pick up the benefit. And also, in some of the mycophenolate studies, patients were also treated at the same time on a low dose of prednisone, which really led us to learn that you can get away with treating somebody with a very low dose of prednisone. So mycophenolate, is commonly used. Less commonly used is tacrolimus or cyclosporin. They are effective, but about a third of it. It can have a lot of effects with high blood pressure and kidney problems. A third of patients can have problems with that, so you have to monitor blood pressure and kidney functions really closely with tacrolimus or cyclosporin. Cyclophosphamide or Cytoxan, I reserve this for people that are refractory to everything, because it has a lot of side effects. It's a chemotherapy. It can suppress the bone marrow. And basically that's what it does. It suppresses the bone marrow enough that you don't make the white blood cells that make the antibodies, but it comes with a lot of increased risks, blood in the urine, increased risk of cancer. So that's sort of my treatment of last resort. Rituxan, and I put a double asterisk there. So we often don't use it frontline or as a first or second treatment for acetylcholine receptor antibodies. There was recently a large NIH trial in patients with generalized myasthenia gravis, and it was negative. That surprised a lot of people. And again, it might be like mycophenolate, that maybe it works in a subset of patients, but we have a hard time knowing what that subset of patients are. So I still will use it in some patients with acetylcholine receptor antibodies after they've tried everything. But it's harder to get it, and it will be harder to get insurance to pay for it as soon as this trial gets published, which it should be published in the near future. What Rituxan does seem to be remarkable in is in the MuSK cases. And for patients that have MuSK, Rituxan has become my first line treatment, because I've seen patients, I can give Rituxan, and it really puts patients in a remission for often 2 or 3 years, and I don't have to bother with prednisone or some of the other. Be interested in Gil's or other panel discussions, but Rituxan is my first line for MuSK. And we can go on. Next slide, please.
Do you not see that, Dr. Amato?
Now I see it. There's just a very huge delay. So
yeah, there is a. Okay, there is a long lull. Okay.
Yeah, so I see. So now's my slide, and again, I don't know if Gil mentioned the eculizumab study, the Regain study, and that's a novel treatment that was just recently approved. Next. And I think Gil showed some of these slides, I believe, and it showed how eculizumab, which is an antibody that binds to complement, and it's thought that in patients that have acetylcholine receptor antibody, you have the antibodies bind to the acetylcholine receptor. And when those antibodies bind the acetylcholine receptor, what it does is recruit what's this molecule called complement. It complements like a power drill, and it just kind of drills a hole. And eculizumab binds complement, so you don't get disruption and the hole being drilled and the disruption of the neuromuscular junction. And again, scores improved. Next slide. And Gil, I think, showed this really, and it worked really quick. So the red is the placebo, and the blue is the patient that got eculizumab, and and you can see how the scores dropped, which means it's better, and often within the first, sometimes in the first month, usually within the first 3 months. So it seems to be a very good drug. Next. Biggest risk, though, is that complement is what the body's defense is to prevent infections like meningococcal vaccines. That's how the body gets rid of these bad bacteria that can cause meningitis. So you get complement binds to the bacteria and drills a hole in it and kills it. So if you're giving a drug that blocks complement, people are at increased risk for meningococcal vaccines. So you need to be vaccinated if you're going to get it. And often, because the vaccines aren't 100%, I usually prescribe it. In some countries like Japan, also prescribe an antibiotic, prophylactic antibiotic like penicillin the entire time patients are on meningococcal vaccine. It's also very, very expensive. So it's probably not going to be your primary choice for treatment because you're going to try other things that are cheaper. But it does work fast, and I think it would be a great drug to work for myasthenic crisis, you know. But it's so expensive, it might be hard. There hasn't been a study in crisis, and it might be hard to get insurance companies. You'd have to show that it's better than IVIG or plasma exchange because it is so expensive. Next. Gil mentioned also about the FcRn blockade, and that's sort of like the body's own way of plasma exchange. So immunoglobulins or antibodies are usually taken up by white blood cells and lysosomes and degraded. If they bind to FcRn receptors, then they don't get degraded. The antibodies don't get degraded. But these new drugs that are under development block these receptors so that the antibodies, the myasthenia antibodies, can get degraded. And as Gil mentioned, there's quite a number of trials that are underway, being planned or published preliminary results. And many of them do look promising. So I think we're going to have at least some of these approved. Some are intravenous, some are subcutaneous. I think subcutaneous will be, again, for various reasons, so you don't have to go to an infusion center and maybe go and do it yourself. Subcutaneous, like subcutaneous immunoglobulin, it might be better, more convenient for people. There are other complement inhibitors that are being studied too. So aside from eculizumab, other complement inhibitors are being trialed, including some that are being given subcutaneously. So that could be, again, very promising emerging therapies. Next. And again, I don't know, this is how the cartoon that kind of shows how immunoglobulins can be taken up by lysosomes and degraded. Next. And if antibodies bind to FcRn, they don't get degraded, but if we give a drug that blocks it, then the immunoglobulin can be degraded. Next. So another case to finish up, a 52-year-old woman presented to me when she was 37 years old. So I've followed her for a while. She had nasal speech, problem swallowing, shortness of breath, proximal arm and leg weakness that developed shortly after a birth of a child. Next. On exam, her speech was nasal. She couldn't close her eyes, open her mouth. She couldn't lift her head off of the bed when she was lying flat. She had mild weakness in her shoulders and hips. She couldn't sip water from a cup. She didn't have any ptosis. Even when I had her keep looking up, her extraocular movements were full. Her forced vital capacity was okay, it was 80% of predicted. So next. Chest CT was normal. I did acetylcholine receptor antibodies. They were negative. She did have a decrement on repetitive nerve stimulation. Next. Initially treated her with prednisone and Cellcept with only minimal benefit. Tried IVIG and plasma exchange, which were mildly beneficial, but again, she was still pretty bad. Next. And then finally, again, this was a while back, this case, but this is when Musk, I'm going back in my history, was first found. And then when it came out that Musk this is the way the Musk patients can look, and Musk became commercially available. I got it. I treated her with Rituxan, and she had this dramatic improvement within a month. And now, again, this is what made me a believer. She relapses every 2 to 3 years. I have her on nothing. When she starts having symptoms, I treat her with Rituxan. Our symptoms go away. She's good for 2 to 3 years. And I think that's it. Do I have any other slide? That might be it. And so now I can take questions.
That is it. Yeah, we can answer a couple questions before our last session. How common is it to have myasthenia symptoms only on one side of your body?
It's very common, like in an eye, but it often fluctuates. I haven't seen, the only time I've ever seen that is in like the distal myasthenia gravis early on.
Mm-hmm.
They might have just a wrist or finger flexors, but I haven't really seen it. I don't know if Gil's still on. Boy, I would be very cautious of a diagnosis if they only had symptoms on that was so asymmetric outside of the eye. Okay.
And stress seems to really exacerbate one of our listeners' symptoms. Why does stress have such a big impact on MG patients?
What? Rest?
Stress.
Oh, well, it's probably stress affects the immune system. When your body's stressed, your body's natural reaction is to make antibodies. You're at stress when you're infected. Your body makes antibodies, and maybe it's, that's one thought is that, that's what's going on. You're making more of all the antibodies, including the bad antibody.
Okay. And do you recommend a zinc, calcium, magnesium, and vitamin D combination vitamin? This person was taking that prior to her diagnosis for COVID-19 prevention and was concerned about the MG in the supplement, magnesium.
There's no evidence that would work. I'm very cautious of magnesium. Magnesium can make people worse.
Okay. Good to know.
With myasthenia. It works on the neuromuscular junction, and it can cause weakness.
Okay. Could you explain modulation, AChR versus binding?
Binding antibodies, the antibody binds to it, and then usually that leads to cross-linking of antibodies and complement. And then they're often destroyed by complement. Modulating some antibodies that could bind to the receptor, and it may not cause destruction, but it just they could either block acetylcholine from binding, or it just modulates the way it works. So it probably has to do with what the antibody does. The most common, though, is binding.
Okay. All right, perfect. All right, well, we are at the end of our time, and so I just want to thank you very much for hopping on Saturday afternoon, and we appreciate your talk. Thank you.
Not a problem.